Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Alnylam Pharmaceuticals, Inc.
Hello, I'm Kevin Alexander, Assistant Professor of Medicine and an Advanced Heart Failure and Transplant Cardiologist at Stanford Medicine and a member of the Stanford Amyloid Center in Palo Alto, California. It's my pleasure to present this talk today, Recognizing and Managing Variant ATTR Amyloidosis with a focus on early clues in Black patients. We're first going to talk about understanding variant ATTR. So transthyretin amyloidosis is a progressive and potentially fatal disorder caused by misfolding of transthyretin protein. The primary source of production of transthyretin is the liver, and normally this protein is secreted as a tetramer. In people that have amyloidosis, these tetramers can dissociate into monomers, and these monomers are thermodynamically unstable and toxic and have increased propensity for misfolding and forming oligomers and subsequently the mature amyloid fibrils that deposit in various tissues such as the heart, leading to progressive thickening of the heart and gradual dysfunction such as heart failure and arrhythmia, and that can lead in the end stages of that pathogenesis can lead to death. Amyloid can affect a wide range of tissues. In particular, amyloid diseases that affect the heart confer significant morbidity and mortality due to the progressive nature of heart failure and arrhythmia. When we look at the causes of cardiac amyloidosis, there's a range of proteins that can lead to this disease. Shown here are the most common forms of cardiac amyloidosis. There are more rare forms of cardiac amyloid caused by abnormal aggregation of immunoglobulin light chain, and that's called light chain or AL amyloidosis. And this can affect a variety of tissues, including the heart. And there's a few thousand cases of this in the US per year. The much more common type of cardiac amyloidosis is due to transthyretin, which is a protein that we discussed earlier. When a normal copy of this protein misfolds, this is known as wild-type ATTR amyloidosis. And this tends to be a disease that manifests later in life, with many patients being at least 60 years of age, but most older than that. And it's an underappreciated cause of heart failure with preserved ejection fraction. We're going to focus today on the other subtype of transthyretin amyloidosis called hereditary or variant ATTR amyloidosis. And this is where patients have a mutation in the transthyretin protein, such as a point mutation, that increases the propensity of the TTR protein dissociating into monomers and subsequently leading to amyloid formation. So before we move on, please answer the following question. There have been many mutations that have been described that cause variant or hereditary ATTR amyloidosis. Some of those mutations are shown here. And I'd like to just highlight the fact that there is a heterogeneity in the phenotypic manifestations depending on the mutation that you're looking at, with some mutations being more associated with the predominant cardiac phenotype and cardiomyopathy, other ones that have a neuropathy predominant phenotype, and then other mutations that have a mixture of both cardiomyopathy and neuropathy. So knowing the mutation can give some clues into the potential disease course for that particular mutation. When we look at ATTR cardiac amyloidosis, the burden of the disease is disproportionate across race, ethnicity, as well as sex. Shown here are data from a study looking at death certificate information from the Centers for Disease Control and ascertaining reported amyloidosis mortality. And what you can see here, Black individuals have a twofold higher rate of amyloidosis compared to other races, and men have a higher rate compared to women. Much of this increased disparity of disease is driven by the prevalence of the V122I or V142I, depending on the nomenclature you're using, variant. This variant is carried by 3 to 4% of Black individuals and confers a disproportionate burden of heart failure related to ATTR cardiac amyloidosis. So, next, I'd like to talk about bilateral carpal tunnel syndrome as a potential red flag for ATTR cardiac amyloidosis. So, it's important to note that many patients with ATTR cardiac amyloidosis have a past medical history of bilateral carpal tunnel syndrome. Many times, with this diagnosis being made 5 to 7 years before clinical cardiac amyloidosis is diagnosed. And this is largely due to the fact that amyloid, while it builds up in the heart, can also build up in tendons and ligaments, such as the carpal tunnel. And this can lead to symptom onset that's earlier than what we see from a cardiac standpoint. It largely has to do with the fact that you need less amyloid to potentially cause symptoms in that tight carpal tunnel space compared to the heart. Now, certainly many patients can have a history of carpal tunnel syndrome and not have amyloid. So it's in the right clinical setting that carpal tunnel syndrome should raise suspicion for possible underlying cardiac amyloidosis as well. So let's take a look at this case vignette. This is a 60-year-old Black male who presents with symptoms of mild heart failure and bilateral carpal tunnel syndrome. This is a journey that many amyloidologists would say is familiar. So this patient had a right carpal tunnel surgery in 2007, then had a decompression surgery in 2009 on the left side, and then about 10 years later started to develop signs of heart failure. So first with lower extremity edema, and then ultimately had a clinical diagnosis of heart failure made later that year. And then in this particular example, the diagnosis of ATTR as the underlying cause for that heart failure was made subsequent to that in 2019. So this gives you an idea of what a potential patient journey could look like from the time of initial symptom onset from something like carpal tunnel syndrome to confirmed ATTR diagnosis. So there have been observational studies looking at this relationship on the timing of carpal tunnel syndrome and the development and prevalence of ATTR amyloidosis. Shown here is the Cactus study, which aimed to look at the prevalence of undiagnosed cardiac amyloidosis in patients 5 to 15 years after they've had bilateral carpal tunnel release. This was a study done in Denmark in patients aged 60 to 85 years old. And what they found was that about 4.8% of patients were ultimately diagnosed with cardiac amyloidosis. This was higher in men over the age of 70 and men who had a BMI less than 30. So in this group of patients, carpal tunnel syndrome can be a novel cardiac risk factor to consider. So currently, patients will develop unstable TTR, which then starts to aggregate and lead to carpal tunnel syndrome, and then years later manifest with cardiac amyloidosis. Is there a role for implementing disease-modifying therapies such as transthyretin stabilizers earlier before there's cardiac infiltration? Remains a open question and area of active investigation. So before we move on, please answer this question. It's important to note that there are a number of potential clinical manifestations and red flags in patients with ATTR amyloidosis. While many patients will have a degree of cardiac involvement, this is a systemic disease, and that means that patients, particularly variant patients, can present with extra cardiac manifestations, whether they're gastrointestinal manifestations, diarrhea, constipation, weight loss. We've talked about some of the orthopedic manifestations, such as carpal tunnel syndrome, but also spinal stenosis, ruptured bicep tendon, and things like trigger finger. And then patients can have concomitant neuropathy, whether that's a peripheral sensory and motor neuropathy or autonomic neuropathy. So next, I'd like to talk about the multisystemic burden of variant ATTR. We see ATTR-CM patients in a number of clinical scenarios. We know that among middle-aged and elderly individuals, it comprises about 16% of heart failure with preserved ejection fraction, have symptoms related to diastolic dysfunction such as shortness of breath, leg swelling. As this disease progresses, the heart failure can worsen and may or may not lead to a reduction in left ventricular ejection fraction. Some patients might have underlying atrial fibrillation as an early manifestation of their cardiac amyloidosis, but also potentially ventricular arrhythmias and conduction disease leading to bradycardia. There are about 1 in 6 patients with low flow, low gradient aortic stenosis who have underlying concomitant ATTR amyloidosis. And when we look at other um, conditions such as hypertrophic cardiomyopathy, where patients are thought to have this disease entity, in fact, actually have ATTR cardiac amyloidosis, and there's observational studies to suggest this is a prevalence of about 5% among the HCM population. When we think about natural history of disease for wild type versus variant or hereditary ATTR, observational studies uh, would suggest that variant patients tend to have a more aggressive disease course and shorter survival. And this has been seen as well in clinical trials. So it's important to note, in addition to disease modifying therapies for ATTR amyloidosis, that supportive heart failure treatments are another pillar to our management of these patients. In other forms of heart failure, we consider classes of medications such as beta blockers, angiotensin receptor blockers, and mineralocorticoid antagonists, as well as SGLT2 inhibitors. While the data are less specifically for the ATTR amyloid population compared to other forms of heart failure, we'll consider these classes of medications depending on the patient scenario. Factors to consider would be concomitant cardiac conditions that would be treated with these classes of medication, as well as patient tolerance, as many patients with more advanced ATTR amyloidosis become intolerant of some of these class of heart failure medications due to hypotension and orthostasis, as well as acute kidney injury and hyperkalemia. So before we move on, please answer the following question. It's important to note that social determinants of health have an impact on outcomes in cardiac amyloidosis as they do with other diseases. Shown here is a study from the Johns Hopkins Amyloid Center, which shows worse outcomes among Black patients as well as those who come from a higher social vulnerability area, really highlighting the fact that not only are subtypes of ATTR more likely to have a worse course, but there's also race and social determinants factors that have an influence on outcomes as well. This is another study looking at data from the Stanford Amyloid Center. When you look at components of social deprivation, the SDI, that when you delve deeper into looking at some of the components of social vulnerability, a high proportion of poverty as well as limited access to transportation are strongly associated with increased likelihood of presenting later stage disease at the time of diagnosis. And so highlights some structural barriers that can lead to delays in the diagnosis of ATTR cardiac amyloidosis. So to elaborate further, what are some causes for diagnostic delay in ATTR-CM? Some of it's access to the appropriate confirmatory tests, but now that we're utilizing nuclear scintigraphy scans more as a non-invasive alternative to heart biopsy, access has increased and improved over recent years. There can be misdiagnosis of ATTR-CM with other more common types of cardiomyopathy, such as hypertensive cardiomyopathy. There's really importance of having a multidisciplinary approach to ATTR-CM patients, given that it's a systemic disease. And sometimes the extra cardiac manifestations are the initial reasons why patients present to the healthcare system. And so it really requires a high index of suspicion across multiple providers in the healthcare system. So now I'd like to discuss diagnostic strategies for variant ATTR. There have been a number of screening algorithms that have been proposed over the years. One such one is shown here in terms of who are appropriate patients to consider screening for ATTR-CM. Certainly, if you have a patient who has a history of heart failure or red flag symptoms, such as some of the ones we've discussed, and they have evidence of increased left ventricular wall thickness in an older patient, so over the age of 65 for men or 70 for women, then it's reasonable to screen for ATTR cardiac amyloidosis in this group of patients. You can use a scintigraphy scan as long as you've ruled out a monoclonal gammopathy by checking serum free light chains as well as serum and urine electrophoresis with immunofixation. If there is a monoclonal gammopathy present, then you'll need to pursue a biopsy, such as a heart biopsy, to confirm the diagnosis and to ensure that the patient doesn't have light chain amyloidosis rather than ATTR amyloidosis, which would be treated completely differently. So here's a summary of the diagnostic algorithm that's been published in guidelines. So once you've confirmed the diagnosis of ATTR cardiac amyloidosis, either with scintigraphy or by biopsy, it's reasonable to pursue TTR genetic testing to determine whether or not your patient has variant or wild type ATTR. It has implications in terms of the clinical course for that patient, as well as likelihood for potentially having extra cardiac manifestations, which are more common in variant patients, such as neuropathy. And it also has implications for consideration of genetic testing in first degree family members if it's a patient who has variant ATTR. For some variants, it's important to note that scintigraphy scans might yield a false negative result. The wider utilization of scintigraphy scans have led to increased access for confirming the diagnosis of ATTR. It's important to always remember to utilize these tests in the proper way. If someone has an underlying monoclonal gammopathy, then patients could have a abnormal scintigraphy scan, but have light chain amyloid instead of AL amyloidosis. So one should always screen for a monoclonal gammopathy, and if one's present, pursue biopsy for confirmatory testing rather than utilize a scintigraphy scan. It's important to use SPECT imaging while performing a scintigraphy scan to rule out the possibility of a false positive due to blood pooling rather than true myocardial uptake. And in patients who have a negative PYP, it's important to note that some TTR variants have been reported to yield a false negative scintigraphy scan. Therefore, for these variants, if a suspicion for cardiac involvement remains, one should consider pursuing an endomyocardial biopsy for a definitive diagnosis. So there's increasing importance to decrease the door to diagnosis time in cardiac amyloidosis, particularly when we think about patients in the community who live at a distance from amyloid centers of excellence. And a number of algorithms have been explored in order to shorten that time from symptom onset to diagnosis. One potential modality to aid in the earlier detection of cardiac amyloidosis is to use AI enhanced ECG and echocardiography screening to look for early clues on these commonly used cardiac imaging tests to prompt healthcare providers to consider additional testing and referral for amyloidosis workup. When it comes to staging for ATTR amyloidosis, several biomarker staging systems have been developed for ATTR cardiac amyloidosis, such as the NAC staging system, Columbia, and Mayo. They use a combination of certain cardiac biomarkers, such as NT-proBNP, troponin, as well as oral diuretic requirement to stratify patients in terms of their prognosis and outcomes. Patients with higher levels of these cardiac biomarkers suggest to have more injury, and patients who have a higher dose of diuretic requirement are more likely to have more advanced heart failure. And this can be helpful information at the time of diagnosis to help patients understand disease course and trajectory. There have also been studies looking at trends in certain biomarkers, such as change in NT-proBNP, as potential signs of progression or stability of ATTR amyloidosis, and increases in oral diuretic requirement being signs of disease progression. So, what are the consequences of a delayed or misdiagnosis? ATTR-CM is a progressive disease where fibril deposition continues to happen unabated unless disease-modifying therapy is started. This can lead to worsening of heart failure in patients having significant functional impairments despite starting these treatments. And so It's important to identify at-risk patients, pursue accurate testing, and start treatment as soon as that diagnosis has been made. So before we move on, please answer the following question. Next, I'd like to talk about optimizing management and variant ATTR. So when thinking about treatments for ATTR amyloidosis, there's a few buckets of treatments that one should think about. First would be disease modifying therapies. And so these are treatments that directly intervene on the pathogenesis of ATTR amyloidosis. In the last several years, there have been 3 treatments approved specifically for treating ATTR-CM. There are medications called stabilizers, which are small molecules that bind to the transthyretin tetramer, thereby significantly decreasing the dissociation to monomers and subsequent new amyloid formation. The 2 stabilizing drugs that are available are tafamidis and acoramidis. The other class of medication that's been approved are transthyretin silencers or knockdown agents. So tafamidis was first approved, then acoramidis, then vutrisiran. This is a medication that decreases the expression and production of transthyretin in the liver, thereby decreasing the amount of new amyloid that forms. Each of these therapies have been shown to significantly improve cardiovascular outcomes for patients with ATTR-CM. We think about treatments specifically for managing the heart failure that many of these patients have. And that includes adequate titration of diuretics for decongestion, thoughtful consideration of adding certain heart failure therapies depending on the specific patient profile. And in more advanced cases, we may think about things like heart transplant and the appropriate patient scenarios. In addition to heart failure management, many of these patients have concomitant arrhythmias. And so atrial fibrillation management with a rate or rhythm control strategy, it's important to consider. These patients have a high rate of cardioembolism, and so anticoagulation is important. And for patients who have conduction disease, we may consider cardiac devices such as pacemakers and CRT devices. So we've talked a little bit about how to measure some signs of disease progression, such as worsening in biomarkers and increasing diuretic requirement. There are other functional and patient-reported parameters that we also can consider as well in the trials as well as in clinical settings. Things like exercise testing and 6-minute walk testing can give us clues about functional status and trends over time. Patient-reported outcomes such as the Kansas City Cardiomyopathy Questionnaire can also give us important information about disease trajectory for patients. So before we conclude, I'd like you to answer this question. So in summary, hereditary ATTR amyloidosis is a systemic disease, and many of these patients can have extracardiac manifestations. We discussed the importance of recognizing bilateral carpal tunnel syndrome as an early clue. It's important to implement early diagnostic and screening pathways and consider culturally sensitive communication and clinical practice as we think about reaching all the diverse communities that are at risk for ATTR amyloidosis. There's resources for further learning and patient education tools that we'll share. There'll be a clinician handout linked with this activity, which can be a point of care tool to help identify hereditary ATTR and Black patients as well as diverse populations. So thank you for participating in this activity, and please go on to the questions that follow to complete the evaluation.